The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, groups dementia-related illnesses under the category of neurocognitive disorders, which are characterized by deterioration in neurocognitive processes or physical deteriorations in the brain that correspond with declines in one or more cognitive domains, such as attention, executive function, language, memory, and learning. The decline of which must significantly impact on the individual's day-to-day functioning, with the level of deterioration used to determine whether the disorder is mild or major. For certain types of neurocognitive disorder, pathology and etiological entities are relatively straightforward. For example, in traumatic brain injury, an external physical force leads to loss in cognitive functioning, while in cases of vascular disease, cognitive decline occurs due to neuronal damage caused after cerebral blood flow is disrupted. For other dementia-related illnesses, such as frontotemporal dementia or frontotemporal lobar degeneration, a relatively rare condition, the pathology and etiological entities are less clear, and in terms of symptomology, share many overlapping features, namely, frontotemporal dementia and other more common forms, such as Alzheimer's disease, have been linked to a pathogenic variation related to abnormal expression of the protein tau, believed to be a significant contributor to neurocognitive decline seen in these and similarly characterized disorders, collectively referred to as tauopathies. Given respective pathology and presumed etiology relies on molecular-level descriptions occurring within the affected area to explain the cognitive decline, rather than an external cause, frontotemporal dementia, Alzheimer's disease, and other disorders, which rely on this form of classification, are referred to as neurodegenerative disorders. This video centers on frontotemporal dementia, reviewing diagnostic criteria, methods of assessment, and fundamental differences between frontotemporal dementia and other disorders where overlapping and common psychopathology are apparent, particularly Alzheimer's disease, the principal disorder requiring consideration during differential diagnosis. The prototypical case studies of frontotemporal dementia, originally referred to as Pick's disease, derive collectively from the observations of Czech psychiatrist and neuroanatomist Arnold Pick, who in 1892 linked progressive aphasia with atrophy localized within the frontal and temporal lobes during post-mortem examinations, and German psychiatrist and neuropathologist Alois Alzheimer, more commonly recognized for providing the first accounts of pathogenesis seen in Alzheimer's disease, who in 1913 examined Pick's case studies using Bielskowski's silver impregnation technique and consequently identified the argyrophilic inclusions in neuronal cytoplasm, which have come to be known as Pick bodies, and understood to represent abnormal expression of the previously mentioned tau protein, believed to play a significant role in the neural cell death and cognitive decline seen in cases of frontotemporal dementia. Today, frontotemporal dementia, or frontotemporal neurocognitive disorder, as it is referred to in DSM-5, or if respective biomarkers are present, frontal lobar degeneration, subsumes several syndromes, including primary progressive aphasia, semantic dementia, and Pick's disease. For a diagnosis of frontotemporal neurocognitive disorder, referred to from here on as FND, the initial criteria for a neurocognitive disorder, featured at the beginning of this video, must first be met, namely, there has been a significant decline in cognitive function, that this decline is marked by an insidious onset with gradual progression, and 3 or more symptoms of either the behavioral variant, language variant, or both are present. For the behavioral variant, neuropsychological symptomology is indicative of loss in social and executive functions. For the language variant, there must be evidence of decline in either speech production, word recognition, object identification, grammar, or word comprehension. The language variant comprises 3 subtypes, namely, semantic, agrammatic or non-fluent, and logopnic, based on specific areas of loss in language ability. Probable diagnosis of FND requires evidence of either a genetic mutation linked to the disorder, such as a significant family history of the disease, or clinical genetic testing revealing the presence of abnormally expressed tau protein, or alternatively, neuroimaging detects abnormal structure or functioning concentrated in either the frontal or temporal regions, or in both. If neither of these forms of evidence are substantiated, then a diagnosis of possible should be given. Neuropsychological assessments can assist to differentiate FND from other neurocognitive disorders, pseudodementia, similar types of neurodegenerative disease, as well as between the behavioral and language variants of FND. The typical neuropsychological assessment should incorporate a range of measures, including several standardized tests and clinical knowledge of neurocognitive relationships and diseases known to affect cognition. The Frontal Behavioral Inventory, a 24-item questionnaire designed for caregivers as those with the behavioral variant of FND, by virtue of characteristic symptomatology, generally possess poor insight into their behavior. It is also bidirectionally scripted to avoid the use of leading questions, with an administration period of around 20 to 30 minutes. The Addenbrooke's cognitive examination, designed to distinguish FND from Alzheimer's disease, referred to here on as AD, takes approximately 15 to 20 minutes to administer, and assesses 6 cognitive domains, namely, orientation, attention, memory, verbal fluency, language, and visuospatial skills. It also comprises a verbal language orientation memory ratio, comparing language and memory scores to identify whether cognitive deficits are characteristic of FND or AD. The American Academy of Neurology 2007 recommend a comprehensive medical evaluation to exclude treatable causes of neurocognitive disorder, in particular, metabolic disorders, nutritional deficiency, and infections, as false positive results are known to occur in relation to vitamin B12 deficiency, hypothyroidism, and human immunodeficiency virus, which can be tested using laboratory analysis of vitamin B12 and folate levels, thyroid-stimulating hormone, and HIV serology, respectively. When distinguishing FND from other neurocognitive disorders, it is recommended vascular dementia be considered during differential diagnosis, as characteristic features are likely to overlap, such as a decline in executive function and maladaptive behavioral changes, when brain damage from a cerebrovascular event is localized to frontal or temporal regions. The two disorders are differentiated in that the cerebrovascular event leading to vascular dementia temporally relates to the onset of cognitive decline, and neuroimaging can, as seen here, reveal the resulting brain damage in the form of white lesions. Computed tomography, CT scans, and structural magnetic resonance imaging, MRI scans, can detect structural changes in the brain, including localized atrophy, indicative of FND, as well as excluding misdiagnosis by displaying signs of generalized atrophy, indicative of AD, or reveal other potential causes of cognitive decline, such as the presence of a tumor or stroke-related damage. However, CT and MRI scans are less sensitive to structural changes during early stages of FND and may initially fail to detect any physical abnormalities. Functional imaging, such as positron emission tomography or PET scan, and single photon emission computed tomography SPECT, measuring brain activity by monitoring levels of blood flow, glucose, and oxygen, which, as seen here, can detect hypoactivity in respective brain regions during initial stages of FND, even when structural abnormalities are absent. FND may be distinguished from AD using fluorodeoxyglucose PET scan to measure levels in temporoparietal glucose consumption, as the two disorders are known to display specific patterns of diffusion, and abnormalities become markedly apparent when compared to healthy controls. Post-mortem examinations, providing accurate epidemiological data for diagnosis, have revealed as many as 30% of cases diagnosed with FND are at autopsy found to have been cases of AD. In living cases, individuals are known to present with both FND and AD, as often occurs in language variant cases of the disorder, particularly the lobogenic variant. Aspiration-related syndromes are the most common form of death in both disorders. Although approximately 40% of cases of FND are known to have a family history of the disorder, and approximately 10% are known to display abnormal tau expression, the tau protein is associated with not only AD, but also aging, vascular disease, multiple sclerosis, traumatic brain injury, and Creutzfeldt-Jakob disease. Both disorders are characterized by insidious onset and gradual neurocognitive decline. However, FND onset typically occurs at a much earlier age and progresses more rapidly than in AD. In behavioral variant cases of FND, decline in social functioning is an early feature, whereas in AD social cognition is often spared for relatively extensive periods, and instead difficulties in learning and memory typically feature during the early stages. Post-mortem FND cases typically reveal localized frontotemporal atrophy and relative sparing of the hippocampus, whilst in AD, atrophy is less localized, though markedly evident in hippocampal regions. Finally, abnormal expression of the amyloid protein is known as an early indicator specific to AD, which can be detected through cerebrospinal fluid and amyloid PET imaging. Thus, the amyloid protein may provide an effective biomarker to distinguish between these disorders.